This is Randall Schell, and I'm producing a part 2 of a 3-part podcast series on Anesthesia Pharmacology Keyword Review 2016. Part 1 included local anesthetics and neuromuscular blocking agents. Part 2 will include opioids, IV induction agents, and inhaled anesthetics in a keyword type review. So let's start right in on opioids. Sites of action is the key word. Opioids act both in the central nervous system at the brainstem level as well as in the spinal cord. We call the brainstem level where opioids act the periaqueductal gray area, and in the spinal cord, substantia gelatinosa or lamina recta 2. There are receptor subtypes, mu specifically, that opioids act at. Mu1 activation results in analgesia, both supraspinal and spinal, and mu2 activation results in respiratory depression. So it would be nice if we could separate mu1 analgesia from mu2 respiratory depression, but our current opioids have both. The action of opioids of binding to the mu receptor inhibits release of different neurotransmitters, including acetylcholine, dopamine, norepinephrine, and substance P. The mu receptor activation results in G protein coupled receptor activation of adenyl cyclase inhibition, that is. And when it inhibits adenyl cyclase, it inhibits ion movement across both calcium and potassium channels. And when there's decreased calcium entry presynaptically, there is a decreased release of the neurotransmitters. So in the upper right, you can see morphine binding to the mu receptor and calcium and potassium channels being affected. Opioid cardiovascular and hemodynamic effects. When you give an opioid, you can decrease sympathetic output from the medulla and increase parasympathetic tone via vagal pathways. Meperidine or Demerol can result in myocardial depression, but our usual opioids like fentanyl, sufentanil, remifentanil, etc. do not have significant myocardial depression. When you administer sufentanil, remifentanil, fentanyl, you can get bradycardia from central vagal nucleus stimulation, that is in the brain. The exception is meperidine, which has a structure similar to atropine and can cause tachycardia. Hypotension can occur after administration of opioids, and that can be due to central vagally mediated bradycardia as well as arterial and venous vasodilation. A patient given morphine, for example, who stands up rapidly can have orthostasis. Histamine release is commonly associated with meperidine worst and morphine some, but not clinically significant with our potent opioids sufentanil, fentanyl, and remifentanil. In fact, if you look at an IV where morphine is administered, occasionally as you go proximally up the arm, you can see a red vein, and that is where histamine has been released. Methadone can prolong the QT interval, and with prolongation of the QT interval can result on R-on-T phenomena and polymorphic ventricular tachycardia or Torsades de Pointes. What about the central nervous system? What do opioids do there? And let's look at that as a keyword review now. First of all, its effect on the electroencephalogram and SSEP is minimal. The BIS is not a great monitor of anesthetic depth when you're using opioid-based anesthetic like remifentanil. High doses of opioids are associated with some EEG slowing and delta wave activity. The opioids do not produce seizures on EEG. The exception is being meperidine. In the case of renal failure, its metabolite normeperidine can cause seizures. But the seizure threshold itself is reduced by fentanyl and meperidine. So for example, if you're doing a regional nerve block on a patient and sedating them with midazolam, and you happen to inject a large dose of local anesthetic intravascularly, the seizure threshold would actually be higher, would take more local anesthetic with the midazolam on board to result in a seizure. If you were just sedating someone or providing analgesia, that is, with fentanyl and no midazolam, and they got the same dose of local anesthetic, their chance of seizing would be higher. There's a slight reduction in cerebral blood flow and cerebral metabolism with opioids, but not nearly as much as Propofol and Etomidate. And when you administer opioids along with the volatile anesthetics, we are reducing the amount of volatile anesthetics that is required to keep a patient from moving. But there is a ceiling effect. Opioids are not total anesthetics. The elderly, we should decrease the dose of opioids. In fact, we should probably decrease it in half, including remifentanil, because of increased brain sensitivity. That's a pharmacodynamic effect. There are some CNS effects listed here, including stiff chest syndrome. Well, why is that a CNS effect? Because potent opioids administered rapidly can cause central-mediated, probably dopamine-affected or GABA receptor problems or issues that results in skeletal muscle rigidity and laryngeal muscle closure, such that if you are inducing a patient with high-dose potent opioids and give a rapid bolus, it can make mask ventilation difficult if they have this muscular rigidity in their chest and their laryngeal muscles close. So if you're going to give, for example, remifentanil, don't give it as a very rapid bolus to a patient, but give it slower. And if you do give it and get this skeletal muscle rigidity and laryngeal muscle closure, neuromuscular blockade can reverse it and relax it. And naloxone can actually antagonize it. However, giving naloxone would also antagonize your opioid analgesia. Meperidine actually has a local anesthetic effect, and when given in the subarachnoid space can act like our local anesthetics that we normally put in the subarachnoid space. However, that is not done very frequently anymore. Opioid tolerance and hyperanalgesia, or hyperalgesia that is. Prolonged exposure to opioids actually activates NMDA receptors, and that's probably important in the development of opioid tolerance and the hyperalgesia that can occur in these chronic opioid-using patients. And these type of patients oftentimes will use a drug like low-dose ketamine in the perioperative period for some of the analgesia. It blocks the NMDA receptor. Now, of the side effects least likely to develop tolerance to when you're using chronic opioids, they are constipation and pupillary constriction. So you'll still have constricted pupils and have problems with constipation. That's one of the last things that you may become tolerant to when using opioids. What do opioids do to the respiratory system? Decrease minute ventilation, mainly by decreasing the respiratory rate. They also inhibit our respiratory centers such that our ventilatory response to carbon dioxide is impaired. There's a shift of the CO2 response curve to the right such that it takes higher levels of CO2 to stimulate the same levels of alveolar ventilation. It does blunt hypoxic drive such that if you become hypoxic, normally you would hyperventilate, but if opioids are on board, you will not hyperventilate as much. The apneic threshold, which is the highest PaCO2 where the patient remains apneic, is higher when opioids are administered. An example of that would be a patient with a laryngeal mask in place, breathing sevoflurane and not paralyzed, breathing spontaneously, administered fentanyl. Their end tidal CO2 will often rise, and if you attempt, for example, to drop them from 55 back down to 50 because you don't want it to be that high, they often will not breathe spontaneously until their CO2 goes back up to 55. Their apneic threshold has risen when opioid has been given. The maximal respiratory depression after intravenous fentanyl occurs very rapidly, after about 5 to 7 minutes, as opposed to intravenous morphine, which takes about 20 to 30 minutes. Be aware that if in the recovery room you administer morphine to a patient, you should not immediately then send them up the floor to their room, because that morphine respiratory depression is peaking at about 20 to 30 minutes after administration. And if you co-administer benzodiazepines, the respiratory depression is potentiated. Opioids tend not to interfere with hypoxic pulmonary vasoconstriction and may be used in a TIVA-based anesthetic when you're performing one lung ventilation. However, inhaled anesthetics, although they block HPV, there's not a huge clinical effect on oxygenation in most cases. Opioids and renal effects and metabolites is the next topic. If you just use a single dose of morphine, there's really no alteration in the disposition, but we're talking about chronic administration of opioids and what happens to them in renal failure. First of all, morphine has a sugar molecule put on it, and that's in the 6th position, and it's called morphine 6-glucuronide metabolite. This metabolite is actually active and has analgesic and sedative effects. So it's not a great choice to give chronic doses of morphine to a patient in renal failure because they will build up this active metabolite. Meperidine has a metabolite called normoperidine, which is actually neurotoxic, and if you give repetitive doses of meperidine to a patient with renal failure, they can have seizures as that normoperidine metabolite builds up. Hydromorphone or Dilaudid is metabolized to another sugar-containing molecule, hydromorphone 3-glucuronide, which is active also and can cause some cognitive dysfunction, CNS excitation, myoclonus. And codeine, you can get prolonged narcosis. Now, the last 3 opioids on this list, fentanyl, remifentanil, and methadone, are much cleaner in a patient with renal failure. Fentanyl is good for use in end-stage renal disease with a lack of active metabolites. Remifentanil, because it's broken down by esterases and independent of renal function or hepatic function, doesn't matter, it's going to be broken down. But you should still decrease the dose in an elderly patient by about 50%. And methadone is considered relatively safe without active metabolites. Here's a question for you. A patient anesthetized with desflurane with rocuronium neuromuscular blockade is undergoing a thoracotomy with 1 lung ventilation, is administered 1 mic per kilogram bolus of remifentanil. What's the most likely effect of this administration of remifentanil? Would you get stiff chest syndrome? Well, they're actually unlikely. The patient's actually intubated, so they're not going to have a laryngeal muscle closure around an endotracheal tube. Decreased cardiac contractility. Opioids don't reduce cardiac contractility. Heart rate would go down as central vagal stimulation and reduction of sympathetic output occurs. Decreased PaO2 would not likely occur because opioids don't affect HPV to any great extent. The next key word is opioids and monoamine oxidase inhibiting drugs, and specifically serotonin and its interaction here. Meperidine or Demerol, if given in a patient taking MAOI inhibitors, drugs like selegiline, phenelzine, tranylcypromine. These drugs can be used in patients with resistant depression, Parkinson's disease, among other diseases. You can get a possible life-threatening reaction called serotonin syndrome, which is associated with excitation, high body temperature, hypertension, sweating, rigidity. It can look like malignant hyperthermia. Actually, patient can go on to have seizures, coma, and death. This is the classic Libby Zion patient who was apparently administered meperidine and was on one of these drugs many years ago and resulted in the duty hour rules in the ACGME. Morphine and fentanyl do not appear to cause this, so they can be used in patients on MAO inhibitors, it appears. Tramadol or Ultram we tend to avoid with MAOIs also. Tramadol is a mu receptor agonist, but it also increases serotonin and inhibits reuptake of norepinephrine. It actually is a prodrug and requires metabolism by the CYP system, which is the cytochrome oxidase system, and it's metabolized from its prodrug state to an active agonist state. Note that SSRIs, tricyclic antidepressants, SNRIs also interact with MAOI inhibitors. Remifentanil is the next key word. It has a potency similar to fentanyl and a very rapid effect site equilibration with the brain of only about 1.1 minutes as it compared with fentanyl. For example, as you're setting up to induce a patient, oftentimes we'll administer fentanyl as we're pre-oxygenating, realizing that it's peaking in about 5 to 6 minutes, as opposed to Remi, which will peak in about 1 minute. Its metabolism, as previously mentioned, is independent of renal or hepatic failure, but we will decrease the dose by 50% in the elderly. If a patient has a pseudocholinesterase issue, i.e. a dibucane number of 20, a qualitative problem or a quantitative problem, it will not affect Remi's metabolism. Remifentanil, when administered as an infusion for extended periods of time, when you turn it off, independent of the duration, it doesn't take long for its plasma concentration to drop in half. In fact, only about 4 minutes. It's considered to have a flat, context-sensitive half-time that's independent of the duration of infusion. Now, there are drugs that not only have agonist action, but antagonist action. And agonists-antagonists are nalbuphine and buprenorphine, and naloxone is an antagonist. Nalbuphine acts as an antagonist at the mu receptor and has sealing analgesic and sealing respiratory depressant effect, and occasionally is used in obstetrics when epidurals are not being administered for whatever reason. If a patient is opioid dependent and is administered nalbuphine, because of its antagonist effect, it can precipitate withdrawal symptoms. Buprenorphine or Suboxone is used to treat opioid addicted patients and maintain them. It has both agonist and antagonist activity, is quite potent, 25 to 50 times the potency of morphine, a high affinity for the mu receptor, and does have a sealing effect on its respiratory depression. Naloxone is an antagonist of the mu receptor and will reverse all opioid effects, including analgesia. If you have a patient who is provided high doses of opioids and you suddenly reverse them, sudden complete antagonism of the opioid effects can be associated with massive sympathetic outpouring, hypertension, tachycardia, ventricular dysrhythmias, increased pulmonary vascular resistance, pulmonary edema, and even death. So if you're going to use naloxone to reverse opioids, I will start usually with about 10 mics and give intermittent doses of 10 mics IV until the patient starts breathing, rather than just giving milligram doses. It has a short duration of action, however, only about an hour, so if you're using opioids or administering opioids that had a long action, morphine, Dilaudid, Demerol, etc., and you give a person naloxone, you must realize that that naloxone will be gone in about an hour, and you may have a patient who becomes re-narcotized. And you may have to give an infusion of naloxone or intermittent doses. The next keyword is opioids, codeine pharmacogenetics. Codeine is actually a prodrug. That means that it needs to be converted to its active form, and that occurs in the cytochrome P450 enzyme system. It's metabolized, actually, codeine to morphine by the CYP2D6. Bioactivation of codeine to morphine occurs there, as well as tramadol is converted to M1, oxycodone to oxymorphone, hydrocodone to hydromorphone. All those need to be bioactivated to be active. Notice the codones are the ones that must be bioactivated, not the morphones. CYP2D6 has genetic variation in activity in different patients, and this is important because about a fourth of all of our prescription drugs, including SSRIs, TCAs, tricyclic antidepressants, that is, beta blockers, opiates, antidysrhythmics, can have an effect on those. HIV drugs, barbiturates can have an effect on CYPD. And as many as 7% of Caucasians can have a defect in this gene such that they don't convert codeine to morphine, and when you administer them codeine, they're going to have hypoanalgesia because of its poor bioactivation. Let's talk about induction agents next, and we'll just briefly talk about thiopental because methohextol is also a barbiturate, Brevitol that is, and thiopental, though, is the prototypical barbiturate, but you can no longer get a hold of it, and so we will not spend a large amount of time on it. GABA receptor is how a barbiturate works, just like benzodiazepines and etomidate acting via the GABA receptor. Increases chloride conductance and hyperpolarizes cells in the central nervous system. That's the mechanism. The reason why you awaken rapidly from an IV dose, like Propofol, like Etomidate with thiopental, it is redistribution away from the central nervous system to lean body mass and eventually out into the fat. Actually, barbiturates have a relatively long half-life requiring hepatic metabolism. Barbiturates decrease cerebral metabolism. You can actually get burst suppression of the electroencephalogram just like you can with Propofol and high-dose inhaled agents. Hypothermia, hypoxia, all those things can cause burst suppression of the EEG and flattening of the EEG. You cannot get flattening of the EEG with high-dose opioids or benzodiazepines. Occasionally, barbiturate comas are used in the intensive care unit to suppress seizures in the setting of status epilepticus or to reduce the intracranial pressure or serum RO2, that is oxygen use of the brain, in the setting of brain injury. Now, Brevitol is still available and is occasionally used in electroconvulsive therapy because you get a better seizure and longer seizure with ECT than you would, for example, with Propofol, which actually reduces the seizure duration. Thiopental is a veno and vasodilator, and you can get a decrease in blood pressure with induction, just like Propofol, except that it doesn't blunt the baroreceptor response as much as Propofol, so a reflex tachycardia still occurs. So of all of our induction agents, Propofol is the one that causes the most hypotension because it not only vasodilates and venodilates, but also blunts the baroreceptor response of tachycardia. In the elderly patient, you need to decrease the dose. We previously talked about the opioids and needing to decrease the dose because of brain sensitivity. Well, in the case of barbiturates, it's not because their brains are more sensitive to barbiturates, but it's because of a pharmacokinetic effect, that is a decreased volume of the central compartment and slower redistribution from the vessel-rich group to the muscle. I just like to think of it going up to the brain and staying there for a longer time rather than redistributing away. It's not because of increased sensitivity. It's a pharmacokinetic effect. Enzyme induction with barbiturates is the next key word. Patients can be taking phenobarbital, for example, chronic exposure to barbiturates, and these drugs can induce the CYP450 hepatic microsomal enzymes. When you induce those enzymes and rev them up, they metabolize drugs that depend on them for their breakdown. And midazolam is one of those. So if a patient is on phenobarbital, or any drug that revs up the CYP450 hepatic enzymes, it's going to chew up, that patient's going to chew up midazolam faster, and you're going to have a decreased duration of action. As opposed to Ativan, lorazepam, which undergoes phase 2 metabolism or glucuronidation and is not dependent upon the CYP450 enzyme system. Also, the opioid prodrugs that we talked about previously, codeine, which must be converted to morphine, codones to the morphones, and tramadol to M1 by the CYPD system. If you actually had revving up of these enzymes, you may actually increase the active form of these drugs and have more of an opioid effect. And also chronic exposure to phenobarbital revs up the enzymes that break down phenobarbital itself, and that's called enhancing your own metabolism or tolerance. Now, porphyria, specifically acute intermittent porphyria, is a contraindication to barbiturates, either thiopental or methotrexate, because they can stimulate the formation of porphyrin in these patients and precipitate acute intermittent porphyric crisis. Let's talk about Propofol next. The central nervous system effects. Propofol puts the brain to sleep and oxygen use by the brain goes down. The cerebral blood flow also goes down. This is compared as to the volatile anesthetics, where yes, the brain goes to sleep and CMRO2 goes down, but the volatile anesthetics are cerebral vasodilators and cerebral blood flow actually goes up. So both blood flow and metabolism are going down with Propofol, and also intracranial pressure. But as you bolus Propofol, remember that cerebral perfusion pressure is equal to MAP, mean arterial pressure, minus ICP. And if mean arterial pressure goes down significantly and ICP only goes down a little, you can see how cerebral perfusion pressure could be negatively impacted by Propofol. and this may not be appropriate for some patients who you're attempting to maintain high levels of cerebral perfusion pressure. You can cause burst suppression and even flatten the EEG with high doses of propofol. If you use propofol for an electroconvulsive therapy, you will get a shorter seizure duration than compared to some of the other IV anesthetics, and that's part of the reason why Brevitol is classically used for ECT therapy. The cardiovascular effects of propofol include venodilation and vasodilation and inhibition of the baroreceptor response to hypotension, which normally should be a tachycardia as your blood pressure drops. But if the baroreceptors are blocked, you do not get the reflex tachycardia. And not only do you not have tachycardia and you're vaso and venodilated, but you also have negative inotropy. So you can see why propofol causes the most hypotension of our induction agents. The next topic is propofol infusion syndrome. In critically ill children and adults that are receiving high-dose infusions of propofol, it has been described where a patient develops unexpected tachycardia, acidosis, their heart function is decreased, and even can have rhabdomyolysis. And the explanation that has been given is it's probably related to the high lipid load of these high-dose infusions of propofol, resulting in mitochondrial dysfunction. Mitochondrial muscles are poisoned in some way. The muscle of the heart doesn't work as well, and you end up with myocardial failure. And when you have this unexpected tachycardia, acidosis, and myocardial failure, and then get resistant bradycardia, you're really close to full arrest, and patients can die from this propofol infusion syndrome. So oftentimes in pediatric intensive care specifically, propofol infusions may not be used to sedate patients who are on ventilators, for example. Bacterial growth can occur in the lipid emulsion preparation, and you should discard unused open propofol after about 6 hours. Let's talk about etomidate next. What happens in the brain? Both blood flow and metabolism go down just like propofol, but they maintain mean arterial pressure. Etomidate has very little effect on the cardiovascular system, so MAP does not drop while ICP does, and so cerebral perfusion pressure, MAP minus ICP, is actually maintained. You can get activation of seizure foci in the brain with etomidate, and when you're doing seizure surgery, supplementing your anesthetic with etomidate or low-dose infusions of etomidate can actually make it easier to map out foci in some patients. It's not uncommon when you induce a patient with etomidate to see myoclonus, that is muscle movement that may or may not be associated with seizure-like activity on the electroencephalogram, but myoclonus or muscle movement common with etomidate. Does occur occasionally with propofol also, but etomidate is the one that it's most commonly associated with. Adrenal cortical suppression in etomidate. Etomidate inhibits some enzymes, including 11-beta hydroxylase, which is involved in the conversion of cholesterol to cortisol or glucocorticoids. Etomidate also inhibits mineralocorticoid activity, but we're normally worried about the glucocorticoid activity effect that it has, and that is it can, even after a single induction dose, reduce cortisol production for hours. We're not talking days, we're talking hours, and rarely is this a clinical issue, but you could see that if you infused etomidate in a patient or gave a dose to a patient who is already cortisol depleted, like an Addisonian patient, ICU patient who's on high-dose vasopressors, for example, for extended period of time, this may not be the greatest idea. And there's some new data that suggests there's increased mortality in some patients administered etomidate, for example, versus propofol for induction. PONV, postoperative nausea and vomiting, is increased with etomidate. Some people call etomidate vomitate. The pain on injection that is classically associated with propofol is also associated with etomidate. There's pain with its injection, as opposed to methotrexate, which isn't very much, and ketamine, which is very little at all. What about ketamine next? The receptors that ketamine acts on is the NMDA receptor. It blocks it. That's its main analgesic action. And it dissociates the thalamus from the cortex, called dissociative anesthesia. The cardiovascular effects are a release of endogenous catecholamines, such that as your catecholamines go up, your blood pressure, your heart rate, vasoconstriction of your pulmonary artery occurs in adults, not so much in kids, and the blood pressure usually goes up, as does heart rate. However, if you have a patient who has spinal cord transection or has been in the ICU on multiple infusions of inotropes or vasopressors, the direct effect of ketamine, which is myocardial depression, can be unmasked. And so if you give ketamine to a patient with an intact nervous system, you will usually see an increase in heart rate and blood pressure. If they have spinal cord transection, you may actually unmask and see the direct myocardial depressant effect of ketamine. There's some other effects and side effects listed here. One, bronchodilation occurs because of the increase in catecholamines, which have beta effects and bronchodilation. Secretions can go up from sympathetic cholinergic stimulation. Emergence delirium can occur with ketamine as the patient awakens. And if you have atropine on board because maybe you used it to try to reduce secretions, atropine crosses the blood-brain barrier because it's a tertiary amine and can make emergence delirium worse. So don't use atropine or scopolamine when you're also using ketamine. Ketamine may not change the BIS, bispectral index, much, even in doses creating unresponsiveness, so you can have a blitzed patient on ketamine and still have the BIS reading 80. Some anesthetic effects on the EEG, somatosensory evoked potentials, in the bispectral index. First of all, the EEG. The classic effect of anesthetics on the EEG is slowing, that is, moving from alpha and beta waves towards delta and theta waves. And Propofol, Barbiturates, and Etomidate tend to do this. The exceptions are the opioids like Remifentanil and Ketamine. The drugs Brevitol and Etomidate can actually activate seizure foci, and if you're doing electroconvulsive therapy or seizure surgery where you want to see more seizures in ECT and see where the seizure is coming from in seizure surgery, supplementing your anesthetic with Etomidate or methotrexate may increase the seizure. The SSEPs that are used often during back surgery, for example, scoliosis surgery, the latency or the time it takes for a signal to go, for example, from the lower extremity to the subcortical in the cortex is increased by our anesthetics, and the size of the signal or its amplitude is less. And our volatile anesthetics and many of our IV anesthetics have that effect on the SSEP, making it harder to monitor, actually. And the exception is Etomidate and Ketamine because they actually make the amplitude of the SSEP signal go up. So if you're having problem with your SSEP signals, supplementing your anesthetic with low-dose ketamine, you might see a higher amplitude and make it easier for the neurophysiologic monitoring tech or physician to monitor that SSEP. As mentioned previously, the BIS is confounded by opioids and also confounded by ketamine and nitrous oxide, meaning that if you had a remifentanil, ketamine, nitrous oxide anesthetic going, your BIS may have a very high number and a patient be totally blitzed. And so BIS is not a good monitor of hypnosis when you're predominantly using opioids, ketamine, and nitrous oxide as your anesthetic. Here's a question for you. All other factors being equal, if a patient was anesthetized with propofol as compared to ketamine, they would more likely demonstrate which one of the following. So we're comparing propofol to ketamine. Would they have greater analgesia with propofol? No. Would they have a lower BIS number? Yes. Would they have a higher cerebral blood flow? Well, propofol reduces cerebral blood flow, and ketamine can actually increase it. And pulmonary vascular resistance, it should say higher pulmonary vascular resistance, and ketamine can actually raise pulmonary vascular resistance. Obesity and IV anesthetics. What do you do in the obese patient with dosing? Well, some general guidelines. Non-depolarizing neuromuscular blocking agents are big, polarized, water-soluble molecules. In the obese patient, there's little change in the volume and distribution of these big, water-soluble molecules. So we tend to dose rocuronium, for example, by ideal body weight, often adding 20% or more to include the extra lean mass that these obese patients have. Succinylcholine, the dose is increased because of increased pseudocholinesterase activity. So if you take their ideal body weight, 1.5 milligrams per kilogram is what we normally use because of their increased pseudocholinesterase activity in the obese patient. Lipophilic drugs go to the fat stores of the body, and the volume of distribution therefore is increased. So drugs like opioids, benzodiazepines, propofol would need a larger loading dose to produce the same plasma concentration, but most will dose on an ideal body weight plus maybe 10 or 20%, although there's some controversy about this. Remifentanil pharmacokinetics are similar to the non-obese. We dose on ideal body weight. In the awakening times for volatile anesthetics, when you're running relatively short anesthetics, less than 4 hours, very similar between obese and non-obese patients, between Sevo, desflurane, and isoflurane, although you would expect the lowest blood gas soluble agents to have the fastest offset. Let's move on now to inhaled anesthetics. First, nitrous oxide. What does nitrous oxide do to the central nervous system? It increases cerebral blood flow. Remember, the volatile anesthetics, DES, ISO, and Sevo, also increase cerebral blood flow, while the intravenous agents, except ketamine, decrease cerebral blood flow. The MAC of nitrous oxide is over 100%, which means that we cannot provide even 1 MAC of anesthesia of nitrous oxide unless we were under hyperbaric conditions. 1 MAC would be approximately 760 millimeters of mercury expressed as a partial pressure. And the only way that we could do that is if we raised the total pressure of the system, and we could do that in a hyperbaric chamber only. Cardiovascular-wise, when a patient's breathing nitrous oxide, there's a tendency of nitrous to stimulate the sympathetic nervous system, and you might get a little change in heart rate and blood pressure and cardiac output that is an increase. And it also can increase pulmonary vascular resistance in adult patients. So remember, ketamine increases pulmonary vascular resistance. Nitrous oxide can increase pulmonary vascular resistance. So if you have a patient with pulmonary hypertension, ketamine and nitrous oxide, probably not the greatest choice. Hypoxic drive is markedly depressed by nitrous oxide, and the volatile anesthetics often also markedly depress hypoxic response. That is, if you become hypoxic, normally you should hyperventilate. If nitrous oxide is being breathed at the same time that you become hypoxic, you will not hyperventilate the same. There are some problems with nitrous oxide. One is chronic exposure can result in megaloblastic anemia and peripheral neuropathy because of oxidation of the cobalt atom in B12 and an inhibition of an enzyme called methionine synthetase, which is involved in myelin formation. If you're messing around with myelin formation, you could see how you could get peripheral neuropathy, and if you're messing around with DNA, you can see how you could get megaloblastic anemia. So a patient chronically abusing nitrous oxide could have huge red blood cells and a diabetic-like peripheral neuropathy. There's some possible teratogenic effects, and we often will avoid nitrous oxide in pregnancy. And we know that nitrous oxide expands closed air spaces because it's 34 times more soluble than nitrogen, and air is 80% nitrogen. So if you have an air space, nitrous oxide will go into it. Nitrogen can't leave as fast, and the airspace will increase in size. And examples of such are air emboli, a pneumothorax, which will double in 10 minutes, breathing 75%, and will triple in about 30 minutes. A tension pneumocephalus can occur, for example, after craniotomy and the dura is closed. If a patient is breathing nitrous oxide and air is trapped in the dura, below the dura, it can increase in size and cause a tension pneumocephalus. If a COPD patient has severe bullous cysts in their lung and breathes nitrous oxide, those bullous cysts can rupture. Middle ear, it can, if it's obstructed, can build up pressure, and grafts on the middle ear can be disrupted. And sulfur hexafluoride is a gas that can be injected in the back of the eye and is used in retinal detachment procedures. If a patient receives SF6 gas, you should avoid nitrous oxide for probably at least 4 weeks or more after its use, because nitrous oxide can expand that SF6 bubble in the back of their eye and increase the pressure. The cuff of the endotracheal tube actually takes up nitrous oxide, and the pressure can actually exceed the 25 to 30 centimeters of water, which can reduce tracheal perfusion if you do not take air out of the cuff over time when you're using nitrous. Ball distension is the classic problem with nitrous oxide. 50% nitrous oxide can double the ball gas volume in several hours, and 75% can put it up to 4 times increase with time. The nitrous tank itself, as you know, is blue colored and contains both a liquid and a gas mixture until all the liquid is used up, and then there's just gas left. When it's full, it will read approximately 1590 liters. That is not read, but actually have 1590 liters of gas in it, and will read 750 psi. Now the pressure gauge will stay at 750 psi as you're using up the liquid, and the liquid is converted to gas, and you keep that constant 750 psi as long as any liquid nitrous oxide is left. When the liquid nitrous oxide is gone, and approximately only 25% of the total tank is left, or about 1/4 of 1,600 liters is approximately 400 liters left in the tank, the pressure gauge starts to drop. And the only way to know how much was in that tank is actually to weigh the tank and not know how much is based on the pressure gauge. Like oxygen, which has approximately 2,000 psi and 660 liters or so, we can follow the pressure and know exactly how much oxygen is left in that tank. MAC is the next topic. MAC is highest at about 6 months of age. Things that increase MAC are anything that increases central neurotransmitters. Acute amphetamine use ramps up the central nervous system. MAOI inhibitors do that. If the patient's hot, if they're chronically using alcohol or have hypernatremia, MAC will decrease as you age, in fact about 10% per decade after age 40. If you're cold, if you're pregnant, probably because of endorphins and progesterone. Acute alcohol, you're already half asleep with alcohol. Any other anesthetic, propofol, opioids, benzodiazepines, decrease MAC. And actually MAC correlates with the solubility of the agent, DES, SIVO, ISO, for example, in olive oil. So potency is associated with solubility in olive oil. The more soluble it is in olive oil, the more potent it tends to be. So it's not blood gas solubility which correlates with potency. Blood gas solubility correlates with uptake or FA over FI. Faster onset, faster offset with lower blood gas solubility. MAC actually decreases with age, as mentioned, somewhere between 6 to 10% per decade after age 40. MAC of sevoflurane is interesting because neonates and infants have approximately MAC of sevoflurane of just over 3%, while older infants and children have less MAC at about 2.5%. We should think of MAC as a partial pressure, not really as a percentage. Desflurane, we say 6% desflurane is approximately 1 MAC, but we should say at 1 atmosphere, because desflurane 6% at 1 atmosphere, 6% of 760 millimeters of mercury is 46 millimeters of mercury, and we could therefore say 1 MAC of desflurane is 46 millimeters of mercury. And it's the partial pressure, not the percentage, that drives the anesthetic across the lipid membranes. MAC bar stands for MAC block adrenergic response, or how much does it take to block the adrenergic response in 50% of patients. Remember that MAC is 1, ED95 or AD95 is 1.3 times MAC. So what it means is as you go from 1 MAC, or 50% of patients will move to incision, up to 1.3 times MAC, 95% of patients won't move to incision. And at 1.5 times MAC, 50% of patients will have blockade of their autonomic response, but 50% of patients will have an autonomic response and rise in venous catecholamines. The Meyer-Overton principle refers to the correlation between lipid solubility and potency. That is, the more lipid soluble an anesthetic is, the more potent it tends to be. we'll end with that and start up in the last part, part 3 of 3. We'll talk about inhaled anesthetics, finish up some pharmacokinetic principles, and some miscellaneous pharmacology topics. But for now, this is end of part 2 of 3, Anesthesia Pharmacology Keyword Review 2016. I hope you have a wonderful day.